Hi, I'm Jenny Evans with HKS Architects. I work at the design and planning industry. And as a clinician, when we have been evaluating some of our recent building projects, it's very disheartening to see that IT implementation isn't implemented the way that we talked about it in our programming and planning sessions, 3 years earlier, obviously. But a lot of times the systems or the thoughts around how this monitor can connect to this device, it will help the clinicians with communication, being able to receive data in a timely manner, isn't manifested. So my question is, I'd like to hear from several of you if possible, when do you think is the best time to bring in IT people? Who are the IT people that need to come into the design and construction planning process, and when should that be? When we're talking about applications, devices, and infrastructure, it's 3 large different components, and typically it's not one person that wears that hat. So how do we improve that so that our buildings and the environments that we're creating can be enhanced with technology rather than hindered?
I'd like to abstain from that question. No, from the IT side, there's several components in the IT department, and we even had difficulty joining the different silos inside the IT department, the infrastructure, the application, the transmission, and of course clinical engineering with a lot of the data we're talking about now. I wish I had a great answer for you. I'd love to hear what some of my colleagues have to say on that.
My personal experience is that in deploying an EMR across the system, what we've done is that physicians were not involved early enough in the decision-making process. We tested NextGen. We have a bunch of other large EMRs and decided it was good. We used Dragon with NextGen. It worked seamlessly. We decided we were going to use it using mainly tablet computers, which would have stylus input. And then somewhere along the line, between that decision and the end product delivery, someone made the decision to acquire our NextGen through an RTP environment. As soon as we did that, Dragon became useless, and we could no longer use our styluses for input. Now, where was that decision made? Was the person making the decision aware that that was going to be what's going to happen? So we're having to live with that now, but I think that there needs to be a lot of people involved, and whenever we make a change, there needs to be thought, how are we changing other things that might affect someone else? So that's a real life situation.
From my perspective, I think what we're battling is silos. Not only silos within the process of standing a building up, but within the IT department. And often, we've added another level of complexity by adding project managers who oversee these projects, often handling their own little segment. They don't understand the technology, they don't understand the building, they don't understand the clinical workflows. They're supposed to help facilitate, but the clinicians on the other side may do this once every decade. So it's unrealistic for us to sit down in a session and say, tell me your workflows and I'll deliver a solution. So building on what Yadin said earlier, I think that we need to move more towards folks that actually understand integration. And that's how my position has evolved over time at Texas Children's. I've been around a long time, so when I'm pulled into those types of meetings, I can say, oh, this touches this, this touches this, this touches this. Hopefully, over time, as we become more sophisticated, our industry will move towards having that type of expertise. I don't care what the title is. I don't care if it's architect or pickle weasel. I just don't care. We need folks who can help the silos understand how to bridge the gaps. One of the things that Pam said about workflows and nursing working around, nursing will tell you what they want. They will be very clear about what they want. We often don't hear it because we don't understand their language, we don't understand the 24/7 shifts, we don't understand all of that, so we don't have the context. But they will tell us, and if we deliver a solution that doesn't work, they'll tell us a couple of times, but then they quit talking to us because they're going to take care of the patient. They will do what they have to do. So I describe these workflows as being a zombie, or just covered in Band-Aids. So you have this huge workflow that's one Band-Aid after another, and until you actually sit down and strip that to the core, you can't understand the impact of the decisions. We've tried to use focus groups. So we actually go into the unit, we talk to the educators, we get there at 7 o'clock in the morning, we bring donuts and coffee because that way the shift coming off night will come in, the shift coming in the morning. And we will sit there and talk to them. Tell us the truth, tell us what's going on. When we brought alarm management data into those focus sessions, for the first time I handed out a chart that said, you had a really bad night. And the person started crying. And she said, I've been telling you that. And I'm like, yeah, I know, I hear alarm fatigue, but until we're able to deliver that and bridge the gaps between those bedside caregivers to our leadership, because you've got risk management, you've got patient safety. When I sit down and say, I want to put a filter, a 10-second alarm filter, those folks are going to say no, the patients will be less safe. And I need to be able to say, not really, this is what it needs. So I think it's a hard road, and the more we understand and the more we reach out to each other to begin to build those models, the better we'll be.
Comment? Amen.
One thing I would add to that is, and we're in a big building process too right now, and Dr. Robin gave a great example there. The system probably cost millions of dollars. At the end of the day, it didn't do what it wanted it to do. It's a pretty simple question. If during the process you ask those, we'll call them dumb questions, keep asking, does it still do this? Okay, we're changing this, does it still do this? You've got to get some of those end users that have the expectation at the end to be sure they're still meeting the expectation when you change the hundreds of components in the middle. And I've uncovered some pretty revealing things by asking what seemed like a pretty dumb question in the middle of some construction and some system integration projects.
I think your question is also is when to bring them in, and everybody's going to say, well, gee, it makes sense to bring them in at the beginning. But until you get those workflows, if you're designing something and you have a floor plan, and you're moving along with that, if you think you're going to do the workflow sometime down here, where you've had a couple of sessions with people in you're going to have an aha moment. Your mission should be to minimize the aha moments at the end, like, oh no. We have to read it out, right? Your mission is to minimize those. You're going to have them, it's just the nature of it. But the earlier in the continuity, I go back to the continuity and say how it's really important to have the continuity through the project and someone that can facilitate. I so agree with that, because you want to get a lot of different opinions, but clinicians don't participate in this through their career, maybe once or twice. So I think if you're in the business of providing devices and services, I would ask that you ask who's at the table. Tell me who these people are, what they do. Ask for the clinician either. Ask for the physician. Make a list of who you want to be at the table, and you can bring that. I think your project will be so much more successful, and you'll be looking good. People may not know.